the clinical application prospects of absorption technology from the perspective of toxin classification. In my presentation, I will go for the EU toxin classification guidelines. This is a guidelines that was published more than 20 years ago with the fundamentals of uremic toxin classification. Then the recent expert consensus on toxin classification with innovation of this new dimension of toxin classification. And finally, in the summary, the new concept of toxin clearance with the clinical outcomes as the guiding principle. First point is the European Toxin Classification Guidelines published in 2003, in which you can find the fundamentals of uremic toxin classification. In 2003, the EU Tox Working Group of the European Renal Association was able to write review paper on uremic toxin classification, concentration, and inter-individual variability. At that time, was a focus on the molecular weight, protein binding characteristics, and concentration variability of toxins to optimize uremic toxin clearance strategies and personalize blood purification protocols. So the principle of classification was to divide proteins in small molecule toxin with the weight of less than 500, medium molecule toxins more than 500, and protein-bound toxins with 45, 22, and 25 types. And also, the concept was that small molecule, that most are water soluble, can be cleared through conventional dialysis. The medium molecule, partially water soluble, low dialysis clearance rate, and the protein-bound toxin binds to plasma proteins, cannot be cleared by conventional dialysis. What was the authors were able to find is that the water-soluble small molecule toxins, such as creatinine, methylgalonide, and urea, uric acid, with the molecular weight between 60 and 168, can be removed, and because they are present in plasma in free form, can be easily cleared by hemodialysis. But some toxins exhibit strong biology toxicity, such as ADMA and TMAO, potentially leading to neurotoxicity, vascular dysfunction, and inflammation. What about the medium molecule, where we were investigating beta-2 microglobulin, IL-6, PTH, and TNF-alpha, with molecular weight between 9,000 and 26,000. These are peptides and cytokines, primarily derived from endogenous metabolism, mostly consist of peptides and cytokine, generally cannot be cleared by low flux hemodialysis, and high flux hemodialysis has limited effectiveness in clearing largest molecules. And among the 22 medium molecule toxins, 12 have a molecular weight higher than 12. So to clear such large molecular toxins, more efficient clearance technologies should be prioritized. And what about the protein-bound toxins? The two major proteins that were investigated was indoctyl sulfate and p-cresol. And these are molecular weight between 108 and 2,251. These are primarily derived from gut microbiome metabolism, hence their concentration is influenced by diet and gut microbiota composition. Most have relatively small molecular weight, but exhibit high protein bind rates, higher than 80%. And in the bound state, their dialysis clearance rate is significantly lower than that of non-bound toxins, and they possess high biological activity and are closely associated with CKD, cardiovascular disease, and metabolic disorders. So traditional dialysis techniques are not effective in clearing protein-bound toxins. So attention should be given to optimize clearance strategies, for example, absorption, to reduce the long impact of such toxins on our patients. The toxicity assessment of uremic toxins and the importance of clearance are primarily evaluated based on the concentration ratio of toxins in the blood. So this is true for indoxyl sulfate, P-cresol, beta-2 microglobulin, PTH, and interleukin 6. And this is very important. So the key conclusion of toxin with the CU and over CN higher than 15, and toxins with the Cmax over Cu more than 4. So the key toxin, the protein bind toxins, difficult to clear through dialysis, and also, for example, the ganidine toxins may cause damage to the nervous system and oxidative stress. The pro-inflammatory molecules such as leptin and IL-6 that may exacerbate chronic inflammation and vascular damage, and the glycometabolic and nucleoside toxins that may affect DNA repair and metabolic homeostasis. So, in summary, in this paper, early toxin classification defined toxins based on their physiochemical properties and molecular weight, a framework that remains in use today. This classification was limited by technology of the time. Although protein-bound toxins were categorized separately, they were not studied in depth or given significant attention. And finally, research and assessment of toxin toxicity were mainly based on concentration differences and were not integrated with the actual clinical conditions of patients. This is why we moved more recently in discussion of new dimension of toxin classification with this recent expert consensus on toxin classification. This is our paper that was published in Clinical JSON in 2021, and then other papers came out after this in the last 3-4 years. And we propose a more comprehensive and refined classification system, considering the physiochemical properties of toxins, toxin clearance technologies and efficiency, as well as the impact on target organs and clinical outcomes. So we move from the previous, the current, the 2003, that have terminology limitation, the chemical identifying biological fluids, the total blood levels, and uremic, reduction of absolute concentration, body fluids of tissue, and uremic. And we suggest an update. Which is this update? Well, in this consensus, the chemical identification and quantitative analysis move from the old definition to the toxins needs to be identifiable and quantifiable in plasma, serum, or blood with the analysis of just specified. The measurement of total toxin levels and plasma concentration, it is recommended to compare the levels in plasma, serum, or blood with those of individuals with normal renal function, and it is pointed out that toxin levels in patients with CKD should be higher than those in individuals with normal renal function. The relationship between toxin concentration and clinical symptoms, that is extremely, extremely important. And the standards for toxin concentration, again, that was one point that we discussed. What were the limitations? Well, one of the limitations was the molecular weight-based classification. So in our recommendation, we recommended the classification of uremic toxin incorporate as dialysis strategies, absorption capacity of dialysis membranes, the clearance modes, and protein bind rates in addition to molecular weight. And with the advancement of dialysis technology, the standards for uremic toxin classification need to be continuously up to date to accommodate new clearance methodology. The principle based on the effect of toxin in target organs, we were able to classify on the basis of toxicity, lead to high mortality or lower quality of life. And this was the uremic toxin in all the tissues and cells that are involved in CKD, such as kidney, cardiovascular, endocrine, immune system, hematology, gastrointestinal, neurological, and nutrition muscle. So this is the systemic disease where uremic toxins can have a prevalent role. So if we were able to reduce the impact of uremic toxins, we are able to reduce the high mortality and to improve the lower quality of life in our patients. It's cardiovascular system, because these are the main causes of death in patients with end-stage kidney disease. So our recommendation was to move from the physiochemical properties and classification and move with toxin should place greater emphasis on clinical consequences. Because the current physiochemical classification does not fully reflect the biological consequences of uremic toxins, nor can it identify which toxins have the most significant clinical impact. So this is just an example of what is possible to see when there are the interaction of uremic toxins with various systems. Research based on the biochemical and clinical impacts of toxins. In ACE, these are the number of toxins affecting specific physiological system, moving from cardiovascular disease to inflammation, metabolic function, fibrosis, and so on. In BDF, this is the number of physiological systems affected by each individual toxin. And you can see all the uremic toxins that we were talking about later on. In AD, these are the small molecule water-soluble toxins, cardiovascular system, inflammatory response. In CAD, the protein-bound toxins, cardiovascular, inflammatory, and metabolic system, and such as the PCS, IS, and AGEs that are the most biologically influent protein and may represent the key therapeutic targets for future treatment of uremic complication. And finally, in ENF, the medium and large molecular weight toxins that have an impact in cardiovascular, inflammation, and bone metabolic systems, such as beta-2 microglobulin, FGF23, tumor necrosis factor alpha, and parathyroid hormone. More efficient clearance strategies, such as high flux dialysis or absorption techniques, are needed. So the cardiovascular and inflammatory systems are the most significantly affected. Uremic toxins interact with various systems. Here just an example of the higher over the skull evidence score 4 or 3, in which you can see P cresyl sulfate, beta-2 microglobulin, FGF23, IL-6, or in score 3, AGEs, index of sulfate, and so on. The high-score toxins may become the focus for future improvements of blood purification technologies and interventions. And protein-bound toxins such as IS and PCS have widespread effects and are difficult to remove with conventional dialysis, potentially requiring additional clearance strategies. The classification of uremic toxins should include the relationships between toxins and symptom burden, as well as clinical outcomes, pruritus, restless leg syndrome, hypertension, etc. Requirement in patients with renal failure symptom burden has a significant impact on the quality of life. For some patients, alleviating symptoms is more important than prolonging survival. Quality of life is more important than quantity of life for some of our patients. So, the solution is provide personalized dialysis prescription tailored to the unique symptoms of each patient. Limitation: the 2003 classification did not fully reflect the biological consequences of toxins, making it difficult for physicians to identify the toxin that require the most attention, those causing, for example, significant symptoms or complications in patients. So, shift towards a clinical classification system that helps identify patient-specific toxins, especially for those with recurrent infection, cardiovascular risk, and other issues. So the clearance kinetics of different toxins vary. In particular, multi-compartmental solids require different equilibrium times to more accurately evaluate their removal effects. The measurement of clearance rate, pre-post removal ratio, no more. So, the most toxins reach the dynamic equilibrium phase for weeks after treatment, and the pre-post toxin concentration could be measured and compared. And this dynamic equilibrium model of toxin clearance is represented in this picture. So a time-based classification can be established for different types of toxin to reach steady-state levels. And standards for toxin measurement can be developed. These are just an example. A for the CMPF concentration, 8 weeks, beta-2 microglobulin, 3 weeks, I-purate, 2 weeks, urea concentration, 1 week. So, improvement measure methods is very important, not only for small molecules, but especially for medium molecule, beta-2 microglobulins, PTH, protein bound. Current measure methods need to be upgraded to include a more comprehensive range of biomarkers, and dialysis protocols should be optimized based on novel biomarkers. So scientifically standardized measurements can help improve patients' outcomes. So the removal efficiency of toxins is related to factors such as the molecular weight, protein bind rate, blood purification methodology, and the type of dialysis membrane. The effectiveness evaluation of blood purification techniques should be conducted for different categories of uremic toxins. Development of a uremic biomarker system, replacement of KT over V assessment methods is necessary. And so this new classification is extremely important to differentiate the treatment and optimize the clearance of uremic toxins in our patients. So there are 5 new dimensions for the classification of uremic toxins. They assess the impact of non-uremic toxins on patient-related outcomes, including quality of life and quality-adjusted life years. Identify novel uremic toxins that could impact patients' outcomes. Development of and validation of point-of-care and accurate tests to measure uremic toxin archetypes for each class. Development, validation, and enhancement of dialyzer membranes with the tunable ability to preferentially remove different classes of uremic toxins. And finally, develop validation implementation of artificial intelligence and machine learning models to predict patients' outcomes based on uremic toxin profiles and match individual patients with appropriate dialysis strategies. So, in this consensus paper in 2023, we propose to move from 2003 to 2021. And this is the exo-endo phenotype, and this is the summary of the concept. Uremic toxin clearance based on dialysis characteristics is represented in this table. We have exogenous and we have endogenous water soluble. And you can see how low flux, high flux HD, high flux HDF, medium cutoff HD, and high cutoff can reach different points with different molecules. Talking about medium cutoff HD, it's clear that is the one that can remove better at the time with the dialysis characteristics. With high cutoff hemodialysis, we lose also albumin. So, protein-bound toxins can easily form ultra-large molecules after binding with proteins, making them difficult to be cleared. High cutoff dialysis can clear such molecules, but at the same time, it will not selectively clear albumin, imposing a burden on patients. This is why the expansion of toxin classification dimension goes to patient-centered treatment strategies with toxin clearance as the means and clinical outcomes as the orientation. Summary of the evolution of toxin classification, looking at the future key direction of toxin clearance from guidelines to experts' consensus. This is a summary from 2003 to 2023 with classification development, impact on target organs, patient symptoms and clinical outcomes, compatibility with the clearance technique. From physiochemical properties to clinical correlation, moving towards personalized therapy. What about the clearance difficulties and clinical pain points? Well, protein bound point, toxin, gaps in absorption technology, multi-comportamental toxins, long equilibrium cycle, impact on target organs clinical outcomes, improvement of blood purification strategies, breaking through technical limitation and optimizing dynamic balance, and then precisely absorb protein-bound toxins, plus HD comprehensively reduce the impact on target organs, accelerate the achievement of toxin dynamic equilibrium, and symptom-oriented personalized regimens. Dialysis plus absorption, this is the golden combination for precise clearance. Future direction, precise blood purification. From classification to clearance, stepping into a new era of precision medicine. I thank you very much for your attention and for listening. Thank you again.